As a leader or a director, the buck stops with me. I don't shy away from my responsibility. That doesn't mean that I can't try to make decisions with the best and greatest amount of information possible.
This is A New Angle, and I'm your host, Justin Angle. This show is supported by First Security Bank, Blackfoot Communications, and the University of Montana College of Business. Hey folks, welcome back. I'm excited today to be joined by DShane Barnett. DShane was recently named Director and Health Officer of the Missoula City-County Health Department and is now just getting started in that position. Prior to that, DShane served as Executive Director for All Nations Health Center, an organization dedicated to providing sustainable, healthy lives for Native people and the broader community through culturally based holistic care. DShane earned his bachelor's degree in sociology from the University of Montana, got a master's in health administration from UCSF, and is now back at UM working on his doctoral degree in public health. DShane has been working on American Indian health for over 20 years and served in leadership roles both at the local and federal levels. We've got a lot of ground to cover with DShane, so let's get into it. DShane, thanks for coming on the show today.
Thank you for having me.
So first off, I got to congratulate you on your new position with the County Health Department. It's a huge job. Well done.
Thank you. Yeah, it is an exciting and anxious opportunity.
And what an interesting time to sort of be assuming a leadership role of that scale.
Yeah, entering a position that a year ago nobody knew what a health director was.
Right.
Today, it's a spotlight in many communities across the world, so yeah.
And this has to be particularly special given this is your hometown and being able to really make an impact.
Yeah, and that's, my mom, I was talking to her and, I haven't officially looked, but pretty sure I'm the first Native health director Missoula County's ever had.
Yeah.
At least in our collective memories, because, Ellen's been there, a long tenure, 30 plus years. So
sure.
First Native health director in Missoula County, and it happens to be the, city where I was born, city where, my husband and I are raising our son here. And yeah, I couldn't be happier and more excited and anxious to try to do a good job.
As you approach this opportunity to step into this leadership role, what are kind of some of your key priorities as you start the job?
My approach to pretty much every endeavor that I try to tackle is communication and relationship building. So I want communication to be transparent. I want it to be two-way. I don't want to be talking at people. I want to be talking with people. Mm-hmm. And then, building relationships. I'm not ever going to be the end-all, do-all answer. I need to have, people that I can rely on who, are experts in this or have a skill and capability to do this, and together bring us together as a team. And that's really, the idea behind a director, a leader. So my master's degree is in healthcare administration and interprofessional leadership, and that's the idea. The leader brings the team together, and is sort of the glue, that cohesion. But the team is really the one that I'm not going to do this on my own.
Yeah. And you're coming in with a tremendous team and such an interesting time. I mean, I just saw I think it was yesterday, the announcement of the mask mandate kind of getting rolled back. We're trying to up vaccinations. And it just seems like a time where there's some unity on some dimensions, and then there's a lot of consternation on others as we approach this kind of, hopefully, a moment of gradual reopening or some kind of a smart reopening. How do you kind of think about that challenge ahead of us?
I mean, there are definitely lessons learned,
yeah,
and there's an opportunity to have a real community and team-based approach at how we move forward. But the other thing that is really important to remember, public health experts are telling us this is not going to be the last public health emergency in our lifetime.
Right.
So we don't get to sit back and be like, all right, COVID's done. We have no more public health concerns for the rest of our lives. No, the lessons that we have learned here, we need to then turn into strategies for how to be better prepared for the next public health emergency. And that'll be a big part of what I want to do.
Yeah, and you said at the onset that, a year ago, or maybe a little bit more than a year ago, many folks didn't really pay attention to public health. They didn't really know what it was, what folks like you work on. Outside of pandemic, I mean, what are some of the challenges, health disparities, social determinants of health, some of these terms that folks might not really understand what they mean?
Yeah, and that's, when some of the interviews I've had in applying for this job, one of the things that they ask is, outside of COVID-19, we all know COVID-19 is a huge deal, but outside of COVID-19, what are some of your priorities? And I do talk about, I know it's a buzzword, social determinants of health, but and health disparities and health inequities. But the fact of the matter is, Missoula as a county, Missoula as a community is better when we are healthier. Mm-hmm. And when I say we, that means across the board. If we keep more people healthier, we all benefit. And so identifying and addressing where those disparities are, what causes those disparities, and instead of slapping a Band-Aid, actually address the root causes of inequities in health and work to keep people healthy. And that's really the job of the public health department.
What are some of the approaches and interventions that kind of we know work? I mean, we had one of your colleagues, Lori Francis, on a year or so ago to talk about the work over at Partnership. And I mean, what does some of the work look like that the average listener who just gets sick and goes to the doctor kind of wouldn't see or wouldn't understand?
In public health, and specifically, I've been working for the last 25 years in Indian health. Mm-hmm. But in those realms, what I think sort of people escapes their thinking is that most of the time we are not dealing with like what we're dealing with right now, a virus or a bacteria where you go in, you take a pill, you get a shot, and everything's better. We're dealing with lifestyle-related conditions, chronic health conditions. Sure. Those are complex, and those 9 times out of 10 can't be solved with, just a prescription or a shot. There are systemic changes that need to be made within the community. There are behavioral changes that need to be made within individuals and families in order to address those illnesses and reduce the prevalence that we see of things like diabetes, heart disease, stroke, obesity, all of these things that are making people within our community sick, and disproportionately certain people within our community are getting sick and sicker than others. These are very complicated, challenging issues that are not going to be solved with a prescription.
And so what are some of the tools? I mean, it's obviously not something that, a physician is the person who's running point on it. There's probably a variety of contact points and systems you can use to make a difference.
Well, and that's, so like I mentioned, my master's degree is in interprofessional leadership. It takes everybody. We all have to come. The doctor is absolutely essential. The doctor is important. What happens within the 4 walls of the exam room is important. It's just that the majority of healthcare does not take place within those 4 walls.
Right.
So when we're talking about, health education, health promotion, the social determinants of health, the fact of the matter is, if somebody does come into a clinic, a doctor's office, and, say they have diabetes or say they're dealing with substance use, and we give them insulin, we give them Suboxone, but then we send them into an environment that doesn't allow them to be healthy, doesn't support them in being healthy, nothing's going to change. We wrote the prescription, we gave them the medication, and we've changed nothing. Right. And so it's how can we then work with families, work with communities, and work with systems so that we're allowing people to not just get healthy, but maintain health.
So maybe let's focus now on your experience at All Nations. I mean, you're kind of wrapping up your tenure there. First off, for listeners that aren't familiar with All Nations, tell us about the organization, what your mission, and what you try to do.
So All Nations has actually been around in Missoula for 50 years, 51 years now. So we were established in 1970. Over the course of those 51 years, we've actually changed name 5 times. So we're averaging about once a decade. I'm for my own purpose, I hope we stick with All Nations for a while. But
I like it.
Exactly. And the organization itself has actually been around now for more than 50 years. We are what's called an urban Indian health program, and we are not part of the Indian Health Service.
Okay.
We receive contract funding from the Indian Health Service just in the same way we're going to talk later about how we receive funding from Headwaters Foundation, we receive funding from the Indian Health Service. We have a contract and 2 grants, that we've at one time or another had to compete for. We get those. So we are not part of the Indian Health Service. We are just funded in part by the Indian Health Service. And, we have put together a comprehensive primary care center. So we have medical, dental went down during COVID, and we haven't brought it back up yet, but we're getting ready to bring dental back up. Behavioral health, which includes both mental health and substance use and addiction services. Our health promotion, which, I talked about earlier. We want to work to keep people healthy.
Yep.
And then we also have our traditional health services. So we have funding from the Indian Health Service for our traditional health practitioner. That includes things like, ceremonies, spiritual counseling, all of those kinds of traditional practitioner services. But all of our services are culturally congruent. So they're designed by Native people for Native people. They're open to everybody. Anybody who wants to use our services can. But what we see in public health is that when services are culturally congruent, they're more effective and more efficient. So they do more and cost less. We can tell people, go to, and I absolutely adore St. Pat's. I'm on the board at St. Pat's. So this is not in any way saying that St. Pat's is not a great organization. But we can tell people, go to St. Pat's and just do whatever the nutritionist there tells you to do. What we see is that is not as effective and then ends up not being as efficient as if we put together a program that actually is culturally congruent, works with their worldview, their values, their family systems. And when we deliver services in a way that is actually congruent to how they think, how they operate, those services are more impactful.
Can you give an example of some of these distinctions? Like, how do you, maybe an example of the right sort of condition where somebody would seek care, and where, if they had gone to St. Pat's, it would have been culturally incongruent, but through your organization, you kind of understand how to deliver the experience?
Yeah, and I mean, like I said, this is nothing at all against St. Pat's. I love St. Pat's.
Of course.
I'm a huge advocate for St. Pat's, actually. But, so one example that I use is that, several years ago, we were trying to, because we didn't have a diabetes prevention or diabetes self-management program in-house. So we were referring people to St. Pat's. And what we were seeing is, even though the staff there was amazing and they were doing, this great job and trying to really work with the patients, what we were seeing was a pretty low success rate. Patients weren't completing the program. And then, even when they were, not that much was really happening as far as,
Sure.
what we look for, A1C, numbers like that. And so then what we did was we brought that in-house and we designed our special diabetes program for Indians. And so then instead of, the idea is we can tell people, go to the good food store and, buy fresh fruits and vegetables. Well, if you've only grown up, going to convenience stores and fast food.
Sure.
Go into the good food store. When you walk in there, you don't even know where to go, much
You're
less.
overwhelmed. Yeah.
Yeah. And so what we did was we actually changed the approach where we developed some activities that allowed them to get familiar with the farmer's market, good food store, but do it in a way that was what we did was, we would either give them lists of ingredients, or we also did a scavenger hunt at the farmer's market.
Okay.
They would, and we would work with them. So we would have staff there.
Sure.
They would find the ingredients, and then we would take them back to All Nations Health Center and say, okay, all of these things that you got, we are now going to teach you how to turn these into a meal. And not only is it a meal, but this is actually traditional food from our people. So we're talking rice, bison, and got to tell the stories of how these foods traditionally were used, cultivated, grown. And in doing that, they were like, oh, I have an investment in wanting to know how to prepare these foods that way. And then they're more likely to actually do that and stick with it than if you just tell them, here's a voucher, go to the good food store and get some fresh fruits and vegetables.
Yeah, I mean, that sort of embodies that holistic term that I've seen prominently featured on your website. Plus, it also speaks to this notion of trust you're dealing with people that have sort of a common just sort of experience and history. And the concept of trust is something that we had wanted to talk about, and particularly in your role at All Nations. You worked with Headwaters Foundation often. We spoke with Brenda Solorzano a couple of weeks ago on the podcast, and she was talking about her approach to philanthropy is one that, and for Headwaters, it's one that really defers to the grantee to make the decisions as to what's right for your organization. What's been your experience working with Headwaters and philanthropy in general? Maybe start there.
Yeah, I mean, so in the work that I do, I've worked with philanthropy for many years, 25 plus years.
I would assume forever.
And, different community foundations, private foundations, healthcare foundations that provide funding. And up until my experience with Headwaters, I would say I know how the game goes. I know how to play the game. That's why, I'm able to get that funding, is because I know what hoops to jump through.
Sure.
I know what's expected of me, and I know how to do it. And Brenda and Headwaters took that approach and completely turned it on its head. And nothing that I have done with them over the last couple of years equates to all the rest of my 25 years of knowledge of how to work with private foundations.
Yeah, so let's draw that out. So prior to your experience with Headwaters, it was the typical kind of institutional approach, this long, drawn-out application process, kind of this really hierarchical gatekeeper-like structure, and you were successful in getting funding in that space. But yeah, I appreciate how you framed it as a game. When you first intersected with Brenda and her team, did you think it was real? Like, what did you think of the approach? Like, and you had previous experience with Brenda too.
Yeah,
right?
And that's kind of, what's sort of framed the beginning of our relationship here, so listeners know. So Brenda was actually my project officer when she was at the Blue Shield of California Foundation. And that was a project on patient engagement for urban Indian health programs. And totally enjoyed working with her, loved her, great support. But that was absolutely the institutional approach to philanthropy in every way, shape, and form. And then here, getting to meet with her and, hear her say, well, things in Headwaters, we're going to use this trust-based philanthropy approach, and it's going to be different. I mean, I was pretty upfront with her, telling her that that's just great, but I don't believe it. Everything she was saying, I thought, that sounds great.
Yeah.
It's in 25 years, I've never seen that actually play out. So you're going to have a hard time convincing me that that's how it's actually going to go.
A New Angle is supported by First Security Bank, Blackfoot Communications, and UM's College of Business. Access to capital, broadband, and education are three ingredients any community needs for success.
Hey, this is Jeff Petticord, and you're listening to A New Angle.
And how did it go? Like, talk about your first grant experience, or talking to peers that were working with Headwaters?
No, and so this was, fairly early on in Brenda's tenure at Headwaters, so didn't really have a chance to talk to other people yet. And if anything, the few people I talked to, we were all very skeptical. And, I let Brenda know that. I was like, Brenda, I get that you're saying trust-based. Trust has to be earned. Like, you're talking to communities who time after time people have come in and said, trust us. Yeah. And then we've been burned. Whether it's funders, researchers, government, health, medicine, like everybody says, come in and trust us.
Yep.
And then in the end, we get burned. So, your approach is going to have to allow for a relationship building process, not just a trust building process. And to her credit, and her staff and her board, they said, okay, we hear you. We understand that we cannot expect trust right out of the gate, so we're going to model trust. And they did. And so our first funding opportunity with them was exactly what she said it would be, in that she came, we sat in my office, and she said, I'm not going to tell you what I'm going to fund. I want you to tell me what you need.
Sure.
And even in that first conversation, She could tell. She's like, DShane, you're telling me what you think I want to hear. I don't want to hear that.
Yep.
I want to hear what you need, period. Flat out. Don't sugarcoat it. Don't try to manipulate it to work for me. I want to hear what you need.
Right.
So by this time, we were already 30, 40 minutes into this meeting, and only because it's Brenda, I was like, all right, I'm going to give this a shot, and I'm going to tell you actually what we need. And we talked, and I had funding for all of it.
Wow.
And I really credit that for All Nation's ability to grow and develop our programs and services in the way that we've been able to.
Sure.
All goes back to Headwaters, to Brenda, and to their trust-based philanthropy approach.
So what was it that they funded that you probably, correct me if I'm wrong, but what I'm hearing is this is probably something that another organization wouldn't have funded or wouldn't have fit their paradigm.
Ish. So
okay.
The two main things that we got funded from them, I think one does fall in line with what a lot of funders would do.
Okay.
And that was our strategic plan. And I
Sure.
was like, we know that we want to develop and grow our services. In order to do that well, we need to be intentional about that. Mm-hmm. The difference, though, is that, to do a strategic plan well and to bring in a consultant who has a proven track record and lots of expertise costs money. Yeah. So that's what I told her. I was like, I don't want to do a $500 strategic plan. And so she said, okay, well, you tell me who you trust to do this. So I chose a firm, KAI, which is Kaufman and Associates out of Spokane, mm-hmm. who has been working in Indian health for longer than I have, for 4 decades, this
Sure.
organization, and has been including urban Indian health. So they understand intimately our work, our challenges, our opportunities, and, they're a professional consulting firm. And it wasn't cheap, So
Sure.
our strategic plan, I paid more for that strategic plan than I've paid for any other strategic plan, and it was worth every dime.
Sure.
And so even though it was a strategic plan, which a lot of funders are on board with, she let me choose
right
who I was going to do, how I was going to do, and how much it was going to cost. But then the other part of that was we as an organization need to have financial sovereignty. We need to not be dependent on any one organization or funder. We need to not be entirely dependent on the Indian Health Service. We need to not be entirely dependent on any federal agency, any state agency, any private foundation. In order to do that, the best way for us to do that is to build up our third-party revenue stream, which means things that we can bill for Medicaid, Medicare, private insurance,
Sure.
that don't come with all of these strings attached like a grant or a contract would. We just provide the service and we get paid. Mm-hmm. And the more we can do and the more we get paid, the more money we have that we can then reinvest into other programs and services. In order to do that, I need people to come through my door. As an organization that for the first 48 and a half years of its existence did not have comprehensive primary care, this, convincing people that, yes, you can come to us was an uphill battle. And I told her, I was like, I need to do an advertising campaign. Nonprofits and private foundations, but most private foundations would be like, no, we are not going to pay for an advertising campaign.
Yeah, that's not their language.
No, exactly. No, they're not. And it's like, we want to pay for, mission, services, probably like, I want to be able to, hold up, something, really colorful and pretty and say that, we paid for this event or that program. And I was like, that's not what I need. If you really want to fund what I need, and I'm just telling you, Brenda, this is what I need. I'm not expecting you to fund this, but you said, tell you what I really need. And this is what I really need. Not only did she fund it, but she threw support behind it and helping us. I'd never done a marketing and advertising campaign in the nonprofit world. Nobody will pay us to do that, so we don't do that. Mm-hmm. So I have no experience whatsoever in marketing and advertising. And so not only did she give us the funding, but she through Headwaters had, connections with people who, actually, had production companies and services and, would help us. And we ended up getting commercials put together put on television, put on the radio. Headwaters facilitated the beginning of our partnership with the Paddleheads, at the time the Ospreys, but now the Paddleheads. And the Paddleheads completely jumped at the chance to help us with all of our advertising. So our commercials were played in the stadium at every game.
Yeah.
On the radio during their games, on the when their games were televised, on the TV during their games, in addition to all of the other radio and TV spots that we were purchasing. And we saw a return on that. People started to know who we were, trust who we were. And, what we saw was, where we, in the beginning, when we first opened our primary care services, it was really slow getting people in the door.
Sure.
We now have enough people coming through the door that we are developing and enhancing those third-party revenue streams.
So you're able to realize a lot of that strategic plan. So, these gifts and this funding arrangement with Headwaters seems like it's catalytic in so many ways.
And that's where I said, if you really go back to it, Headwaters and Brenda get credit for almost all of our growth and development over the last couple of years. It all relates back to that.
Yeah. So as you kind of reflect on your tenure at All Nations and move on to the next role, what are you most proud of, and what do you maybe think like, man, if I had another year, I'd really like to knock that off my to-do list?
Yeah, and that's what I've been telling people is that I'm excited and I'm honored to take on this role at the county. I don't feel like my job at All Nations is done, but it doesn't matter because it is done. But if my intention, and if I were there for another year or two, we are getting a building campaign off the ground.
Okay.
And, so we, right now, all of our spaces are leased. So, and because we're leasing, so we now have 3 different spaces where we lease. So my staff, our programs are spread out across these 3 different locations. For those 3 different locations, I'm spending $12,000 a month in rent.
Gosh,
that's a mortgage.
That's tough.
Like, I should not be giving that $12,000 away every month. I should be investing that back in equity in our own facility. But the other thing is that we want to be able to have a facility that is built around our programs and services rather than building our programs and services around the facility. And so we want to do a building campaign where we build something from the ground up. And we are moving along in that process. We actually have contracted with Native American Development Corps out of Billings, and they are helping us with new market tax credits, TIF, all of the funding tools that are available for development, because this, again, I'm a healthcare administrator. I don't know anything about, development. That's not my world. So that's why we work with them, because they know these things. I am confident that the board and the administration of All Nations Health Center will continue to move that building campaign forward. It feels a little premature for me to hop off right now. And I do really see that as, and that was part of, like I mentioned, that strategic plan. And that was in the strategic plan, was we wanted to have our own building, our own home. And with all of the support that we've got from Headwaters, it's doable. It's in reach.
Yeah.
There's still obviously work that has to be done. But, today I can say that it is in reach, whereas 2-3 years ago I could not say that.
Sure. And that'll be another transformation for the team and the organization and what y'all can do. Yeah. Let's pivot back to the county for a moment in our closing time here together. And, I think, at the onset, you talked about your experience in your master's degree with leadership education and your experience with Brenda and others building trust. And you referenced the importance of, as an incoming leader, building trust with your team. What are the key precepts of trust building that you've sort of learned through your experiences that you intend to bring to the table here?
Yeah, and I touched on it before. It's that communication. The communication is sort of the foundation for the trust. And so having, bilateral communication. So it's not just me telling people what to do. It's, me talking to people and hearing from people, so that we're actually having that exchange of information, and having to be transparent. And, what I always say is that I realize that as a leader or a director, the buck stops with me. I don't shy away from my responsibility. That doesn't mean that I can't try to make decisions with the best and greatest amount of information possible. Hear from different perspectives. Hear from everybody who might be impacted by that decision. Hear from people who have expertise, experience, knowledge that can help me and help inform my decision, so that it's hopefully as effective and efficient as a outcome as it can possibly be. And even when, conflict is actually really important for knowledge and communication. It's not just seeking out people who are going to say what I want them to say. Right. It's hearing people who have different points of views and contrasting points of views, and learning, from their point of view, things that, really I might not have ever considered, or learning about things that I might need to actually learn more about. Conflict isn't fun, but conflict can actually, if managed correctly, can help fuel growth and development.
Yeah, if you get through it productively, there
Exactly.
can be more trust on the other side.
Exactly, yeah.
I think maybe an interesting area to kind of drill on this concept is the COVID-19 vaccine. Yeah. And I don't know, how much work you've done in that space at All Nations, but the tribal communities in particular have been if you're pro-vaccine, they've been a huge success story. The percentage of tribal members who've been vaccinated is ahead of pace nationwide.
Exactly.
Why do you think it's been so embraced by that population?
Because what we have seen historically is that I know that we think of COVID-19 as really, the first pandemic in our lifetime, but it's not the first epidemic that Native peoples have had to face. We've been through many. We're, in addition to COVID right now, we have an MMIW epidemic. Like, this is not our first go around with this kind of thing. And what we know is that any time there is a pandemic, an epidemic, any kind of public health concern, it's going to disproportionately impact our population negatively. And so, knowing that, history tells us that. We have hundreds of years of evidence that shows that that's true, that we are disproportionately impacted. Nationally, the Native organizations, the National Indian Health Board, National Congress of American Indians, National Council of Urban Indian Health, the Urban Indian Health Institute, very early on said, we know that there is going to be a vaccine. We need to start doing that health education right now.
That groundwork now.
Yeah. And so we were doing that, all the way back last fall, before we even knew if and when we would have vaccines. We were already putting out culturally, so I mentioned that word before, culturally congruent health education on, preparing people that there is going to be a vaccine, and that when it comes, this is why you want to make sure that you get it. And, the other thing is that culturally congruent messaging in the mainstream community. A lot of what we see is, protect yourself, do this for you, keep yourself healthy. That's not the messaging that's going to work in our community. For us, it's, protect our elders, protect our children. We have a communal approach, a communal mindset, and there's a responsibility that goes along with that. We have a responsibility to, not bring viruses home to our grandparents, aunties, uncles, kids, grandkids, and part of living up to that responsibility means vaccinating ourselves. And we got that message out. I feel like nationally we got that message out congruently and early enough that I will admit I was blown away by our acceptance rate for the COVID-19 vaccine. I was really blown away.
And so based on that experience, Missoula County's done exceptionally well with getting folks vaccinated, but how do we do better? What have you learned that you think, maybe you can take some of these lessons from crafting culturally congruent messaging and experiences and extend that to the broader population. What are your thoughts on that?
Yeah, I mean, and that's, my personal background, my professional background is in Indian health. So I talk about, culture from a native perspective. But the fact of the matter is there are lots of cultures.
Everybody's got a culture, yeah.
Ranching is a culture, there's, rural living is a culture. So there are ways to adapt messaging to be culturally congruent for people so that, and it's just a respectful thing to do.
Sure.
Give them information in a way that is congruent with their worldview and their approach to life. And, we can do that. And not only that, but, we did this in our community. And I think that's sort of also what set us up for success is instead of telling people what you want them to know, ask them what they want to know. What is it that they're really concerned about? What is it that they really are on the fence about? Because, you can, say as an educated professional, I'm going to tell you this is what you need to know. But if you haven't hit what is really important to them, none of that messaging is going to be effective.
Yeah, start with listening, I guess. Yeah, there's a lot of finger wagging out there on all sides, right? Yeah. And everybody thinks they start from the premise that they're right and you're wrong, and I just have to, if I give you more information, I'll change your mind, and that we know that doesn't work.
Exactly.
Yeah. So, DShane, I want to let you get back to your responsibilities for the day. This has been fantastic. What do you, and we talked about a lot about your new role, but, what's your plan on day one? What are you going to hit the ground running with?
Well, even before day one. So today, today's the 11th. So May 11th, I actually, my next meeting is with Ellen Leahy.
Okay.
The idea is to, hopefully be prepared even before day one. So, I have had a career in Indian health. I've not ever worked in a county public health department. Mm-hmm. So I absolutely am going to have, some learning curve. And yeah, that's my first goal and responsibility is to try to learn as much as I can so that I can hit the ground running as quickly as possible and as well informed as possible.
Super. And for folks not familiar with All Nations, or for folks that just want to learn more about the Missoula City-County Public Health Department, where would you direct them online?
Yeah, so All Nations, our website, www.allnations.health. And then I have to admit, I don't know the county health department website address
people
by
have Google,
exactly
right?
by heart. But if you Google, so it's the Missoula City-County Health Department. And the health department on the county's website actually has a ton of information. I don't know the URL by heart, but I have been on the website many times. It is a treasure trove of information. I would recommend Googling, Missoula City-County Health Department and going on their website and just seeing all of the amazing information that's on there.
Indeed, it has been a treasure trove. I mean, my primary point of contact with it prior to COVID was in tracking, Sarah Cofield's wonderful writing about the smoke. But with all the, the COVID salience, I've been on the site a lot, and it's a great resource for folks. DShane, best of luck, and thank you for joining us today.
Great. Thank you for having me.
Thanks for listening to A New Angle. We really appreciate it. And we're coming to you from Studio 49, a generous gift of UM alums Michelle and Lauren Hansen. A New Angle is presented by First Security Bank, Blackfoot Communications, and the University of Montana College of Business, with additional support from Consolidated Electrical Distributors and Drum Coffee. AJ Williams is our producer, VTO, Jeff Ament, and John Wicks made our music, and Jeff Meese is our master of all things sound. If you have any questions, suggestions, comments, insults, whatever, please email me at anewangle@umontana.edu. If you liked what you heard, tell your friends about it. Thanks a lot. See you next time.